got a full crowd here today. And I have lots of announcements, which is very good. It just means recovery is doing great. So we're gonna go around and we're gonna do introductions. If you could do just name where you're from or why you're here, in connection to prevention. And then, there was, if you have any announcements, now's just the time to kind of promote anything. There is a larger crowd. We do have a couple of people presenting. So try not to, go on for too long, but this is the time to kind of collaborate on everything going on in the community. So the couple announcements I have, let me get my phone. The first thing is there's a flyer up here. I'm not sure if you guys are familiar with Michael Mumfort's program. He works on policy. So he runs a coalition called the Georgians Responsible for Marijuana Policy. If you're interested in getting involved, we are already collaborating with him as much as we can, to kind of keep up with the Delta 8 and the marijuana policies going on. We haven't been allowed to really get too involved because of our funding. Now we are. So if you are wanting to get more involved, there's a summit coming up. I have the flyer up here on November 12th. So if you're wanting to get involved in policy change, it's important. The other flyer I have up here is the annual Central Thrifting event. Winter time's coming around. If you have any coats you want to donate, this is a great event. We're gonna drop it off, it's right here. So those are both of the flyers that I have. Let me pull up my phone so I don't forget anything. Okay, and then Janice, are you on here? You'll say something about Giving Tuesday if you don't mind that, since you have a little bit of the information. And Sai, are you on here? Okay, Sai, so the kind of the last information is we have some of our youth members here, and I like to let you guys know what's going on with our youth committee because they really are doing so much stuff in our community. It's great. They've been very helpful, but none of us ever get to know because our meetings are kind of early. So the first thing is there is a young member named Sai. He's doing a YouTube channel. He has a lot of views already where he's interviewing people in the community about just recovery, about mostly opioid prevention, anybody who's been affected. If you are interested in being interviewed, he's always looking for new people. Just come find me after the meeting so I can hook you up with him and we can continue this YouTube channel for opioid awareness. So that's his project. Sharmata is not here, but she has been a sector leader of ours for the youth. She just won the CADCA National Youth Leader Award for everything that she's been doing in our community. It's a pretty big award with CADCA. So she's gonna get awarded that, and we're sending her in January to get that presented to her. She'll be going over everything we do out there and everything that she's been doing. So they're doing really good stuff. And then
That means we won it twice,
yeah, we had
which is big.
what's his name? Oh yeah,
Vinayak.
Vinayak. I forgot his name. Yeah.
Is it the
Vinayak.
same award Vinayak won?
Yes.
Yes.
Yes, it is. So yeah, we won it twice, which just so you guys know, like this is
It's for the nation.
it's for the nation, and Forsyth County youth have won it twice, like. Whoop, whoop. All right, sorry, I just did that. The other project that's going on right now, her name is Kirtana, and she is doing an awareness campaign called Breaking the Silence, and it is also about just how to deal with stress. I'll be sending out all these flyers and all this information. I always say if there's anybody who wants to collaborate with these youth members, they're kind of our biggest voice, honestly. We can all kind of sit around and say, how can we stop this in our community? But they're the ones going out and talking to each other. So if you're wanting to get involved in any way with any of our youth, let me know. But those are the campaigns that they've got going on right now. The last one is kind of a special presentation. I wish I had like a theme song right now to present it. But I'm gonna start with Claire. Where's Claire? Yes, Claire, if you could please rise. This is Claire. She's with the District 2 opioid data analysis. Is that the correct title? And she and the council have been working with Saharsha. Please rise. And they have completed a billboard campaign, meaning that they kind of came and decided all on their own that they were gonna do a submission. A whole bunch of people in Forsyth County submitted a whole bunch of different ideas for a opioid billboard. And we finally have the winner now. And Claire's here to kind of give a little bit of data on how we got to the place that we got. So that being said, I'm gonna turn it over to Claire, Saharsha. You guys pick the stand right here in front of the camera, if you will.
There you go.
Thank you.
All right, so like you said, I'm Claire Holbrook. I'm from District 2 Public Health in Gainesville. And it's a little early, so sorry. But so I pretty much do all the opioid data analysis for our district, all 13 counties from Forsyth, Hall, over to Hart, and then all the mountain counties up north. So I'm just gonna go through quickly, very, very short, just how we got this started, because of course, every county is affected by the opioid epidemic. Hall County by far in our district, I call it my problem child, honestly, because they by far have more overdoses than any other county, but Forsyth is second. So of course, we're not trying to have a race here, but it's, again, it affects every community. So no one is immune from it. So let's see. So I'm just gonna throw some numbers at y'all just to show y'all that, I mean, of course, this is a problem, and of course, all y'all know that. So opioids in Georgia, opioid involved overdose deaths in Georgia increased 302% from 2010 to 2022. And then fentanyl overdose deaths increased 308% from 2019 to 2022. That's only 3 years, and it more than tripled. So in 2024, there were almost 1,300 opioid related overdose deaths in Georgia. Those account for cocaine, meth, all the non-opioids and the opioids, but opioids almost accounted for 3/4 of them. So it's almost 75% of them were from opioid overdoses. And of course, as you can see, the Metro Atlanta area, all in red, and Forsyth County, of course, is no exception to that. We're just right up there. So this is just a little more information for Forsyth County. The top graph just kind of shows where we're seeing a lot more synthetic opioids like fentanyl. It, of course, is more than tripled with fentanyl overdoses. So from 2020 to 2022, it rose from 10 to 34 deaths. And this is just for Forsyth County. And then there were 16 fatal overdoses in 2024. And right now, thankfully, we are seeing a decline. This is kind of nationwide, but it kind of peaked in 2022 with 39 deaths. But we're kind of going down. It was 21 last year and then 16, or 21, 2023. And then now we're down to 16. So hopefully we're trending down, and we're going to continue trending down. But of course, every day people are losing their lives from addiction. So again, trending down, but we need to keep working at what we're doing so it continues to decline.
Do you think these numbers reported encapsulates everything, or do you think there's some that's missed?
As far as just this data,
Yeah.
because this is straight from OASIS and my EMS and law enforcement data. So they kind of submit through Biospatial. That's just a full comprehensive EMS data system. So we just get every report that whenever EMS responds to it, we get that report. But I mean, these are low numbers as far as everything that can be accounted for. These are probably the lowest numbers.
Because we don't get a report from Northside Hospital at all.
Yeah, correct. Yeah, and I even struggle trying to get like medical reports, stuff like that, trying to confirm it was an opioid involved overdose. But yeah, I mean, these are just baseline numbers. So if anything, they would increase, honestly.
We pass out about 200 things of Narcan and they're supposed to report it. We hand them a sheet and say, if this happens, will you fill out this sheet and call this number? No one's gonna do that. So
yeah, everything, it's usually underreported, but these are just pretty much baseline numbers that we can go based off of.
Would you attribute that decline to like an increased distribution of Narcan?
Yes, so
That's around the same time that it started being more readily available.
yes, that and just awareness, honestly. So I give out a lot of Narcan. Half of my job is doing the data, the other half is doing community outreach. And even just EMS, I am honestly surprised at how many, because I see the medical reports, they say the bystander or a friend had Narcan already on hand, that they had already given them a dose before EMS even arrived. So definitely Narcan is definitely playing a big part in that. All right, so these are just some data just to show demographic wise. Again, it affects every demographic in some way, shape, or form.
she
So-
has to show the screen on Zoom real quick.
Sorry.
They can't.
Sorry to interrupt
Even
your
though-
presentation.
They just can hear me yapping, not seeing anything.
Can I get your slides?
Yeah.
Okay.
Definitely.
Members on Zoom, I'll also be able to get these slides, Claire just told me, and I will send it out in the email. So what you haven't heard, you will get in front of you after the meeting.
How do I do? Oh. I don't, is it, do you have it pulled up now, the Zoom? Or no?
That's good.
Oh, you can see it? Oh, okay.
Okay. I don't know if it's.
Hopefully. We just got a new system. That's all.
Yeah.
Difficulties. I apologize.
Oh, crap.
Well, I already know this data. So pretty much where you don't see the numbers, this right here with the graph up top, that's just pretty much covering all the age gaps that we have. Usually it's 25 to 39. That's kind of the age range we're seeing the most overdoses with. As far as like male versus female in Forsyth County, it's about 60-40 favoring the male side. And demographically, I mean, it is a white dominated population here, but every race, every ethnicity is affected some way. So I think it was about 75% that are white male that are about the 25 to 39 range. So 3/4 of the overdoses are in that demographic. All right, so almost done. Hopefully I'm not boring y'all too much, but I talk a lot about counterfeit pills, especially with the younger generation. I've heard time and time again, and even I have a family member that unfortunately is overdosed and is no longer with us, but they just think they're taking a pill that a friend gave them, like Adderall, to help them study. And the next morning, a parent finds them and they've overdosed because it was a fake pill that they bought on Snapchat or something like that. And they had no idea. They just thought they were getting an Adderall and it had a lethal dose of fentanyl in it. So, of course, counterfeit pills. I mean, I work with the DEA sometimes, and even the DEA agents that have been to like Guatemala, Honduras, Mexico, they even say they can't spot what is fake or real because the cartel is actually able to purchase the same pill presses that like Pfizer and Johnson & Johnson use to make their own pills. So that's just how good they are at faking it, and that's how dangerous it is because let alone DEA agents and myself that have seen this kind of stuff, we can't spot it. Let alone kids that are in high school. They definitely can't spot it. So this hopefully is a good sign. I mean, it's a good sign. Hopefully it continues to go down. But in 2019, about 40% of counterfeit pills had a lethal dose of fentanyl. It spiked up in 2023, about 70% had a lethal dose of fentanyl. So that was definitely a scary time. 2025, this year to date, the DEA sent out a memo saying we are down to 50%. So of course, it's still almost like a Russian roulette game where it's 50-50 shot of whether it's an actual legit pill or it's a counterfeit one that has a lethal dose of fentanyl. But hopefully that trend is going to continue to go down. But just to put into perspective, in 2024 alone, the DEA confiscated 60 million deadly fentanyl pills. That pretty much could have been 60 million lives saved because that's how much that this has been infiltrating every aspect and every corner of this country. So we collaborated with Lambert High School, and if you want to talk about this, but this is pretty much the billboard that we created. So hopefully we can put this up sometime soon. But if you have anything to say, this is just pretty much what we've created to just raise awareness.
Yeah, so I'll just say a couple of the reasons like why we specifically Lambert High School decided to partner with District 2 and Claire Holbrook. So my name is Sahasha and my friend Sean is like not here today. But we have a club at our school that we created called Project Safe, which is Students Against the Fentanyl Epidemic. And through this club, we created like a curriculum for fentanyl awareness to every single health and PE class in the county. And we've targeted over 1,600 students in the county so far. We have the analytics for that. And also we do in-person workshops at middle schools such as Lakeside and South and Riverwatch in their health. We're able to target them early on. And recently, around like May of last year, we heard from Miss Hayden that there was an opportunity to partner with Miss Holbrook to raise even more awareness, not just to students, but to drivers and people, anyone really passing through our county. So we decided to help spread some awareness for this billboard competition through our school, through like schools in our county, and even like schools outside our county like Fulton and Gwinnett. And we were able to receive over 103 submissions for this billboard design competition, but after narrowing them down and sending them to Miss Holbrook, we landed on the one designed by Isabella, and Isabella would like to say a couple of words on why she decided to compete in this competition.
Okay, so I'm originally a senior from Lambert High School, as she mentioned before, and I'm also an art student. So I thought this would be a great opportunity to kind of like intertwine like my passion with like a big awareness that should be spread around the county and even further. And I just wanted to include a billboard that be easy on the eye, especially since it's going by cars, and then you only have like a couple seconds to really look at it and understand it. So I really wanted to make it easy on the eye with the colors and just like the aesthetic in general. And I also wanted to include just the basic information because once you really look at it, you only have a couple seconds to truly comprehend it, especially since it's going by like 60 miles an hour, like no matter where you are. So I just wanted to make it easy and understandable. And we don't know like the ages that are going by, since it can range around like the elderly to even high schoolers as mentioned. And the fentanyl awareness and just like drug awareness in general truly just impacts just every age in general. So I wanted to be able to be more inclusive. And I chose the color red specifically since, coming from an art student perspective, red is one of the most eye-capturing colors, and it just truly shows like it symbolizes like danger as well. So once you see it, you're kind of like eye catch to it and like, oh, what is this about? So I wanted to make that, and I just included like just a little bit of data as it says 5 out of 10 counterfeit pills have a lethal dose of fentanyl, and it just shows kind of more awareness. Because before I got into this competition, I did a little research on my own, and I didn't really know the true effects that fentanyl and Narcan had to this. So I just thought it was a great opportunity to inform myself and others around us.
No, that's pretty much it. So,
Okay,
yeah,
well, it
have an
made
eye out
me
for them
feel
someday.
that these young ladies are willing to come here and present to us and talk to us. It can be a little scary. So you guys did absolutely great. Thank you very much.
To the county.
And if
Yes.
y'all
They'll pick
need
up.
information, my information's right there. You can get with me after.
If you don't get a response.
Awesome.
Did you say we would get that?
Yes, yes, yeah, well, I'll send it all, everything out. We usually go over if I can. Okay, so that is all of my announcements. Now we're gonna go around and introduce ourselves. Claire, we're gonna skip you. Introduce ourselves.
Good morning, Lindsay Simpson, prevention specialist for Forsyth County Schools. I'm housed over in our school department and been around for a while, like Cindy was one of the founding members, helping get our council off the ground. And my only announcement, can I give them a save the date since we have it? So save the date for February 11th. That will be our drug summit that we're gonna have, like our winter, our annual, I guess is how we call that. And it's gonna be at SoCal this year. So we're gonna work on our team and work on our panelists, kind of just in the planning stages. But wanted everybody to go ahead and save the date because February will be here before we know it, so.
And that's a big place. Like
It is, so we're not gonna be in the auditorium, we're gonna be, I think we're in Black Box, which is over to the left, but it still holds, it holds a
250.
good
I don't know,
many.
too.
I'll confirm, I'll look really quick at what she sent me, but where is it? Focal, so it'll be there, but not in the main auditorium, we're on the Black Box, which is over to the left side. Sorry, I just assume everybody knows. Sorry.
I'm Dee Langston, I'm the executive director of the Child Advocacy Center in South County and for the board here in Georgia.
Hey, I'm Carrie Hops. I'm one of the pharmacy managers at Northside Forsyth.
I'm Amy Bowler. I'm an advocacy specialist with CASA.
I'm Adam Miller. I work for Blue Ridge Mountain Recovery Center. I do counseling at a couple of private practices for DFACS kids and adults in the Cherokee County Family Treatment Court. And I'm on the board here.
Hi, I'm Agnieszka Baka-Aga. Adam invited me. I'm a psychology student right now and I'm a recovery, so that's why I'm here.
Welcome.
Hi, I'm Belinda Contreras. I'm with the Forsyth County Health Department, District 2 Public Health as well. And I'm the healthcare program consultant. This is my I'll probably put it.
I am Diane Ward and I'm with DSI. And I'm with Blue Ridge Mountain Recovery Center in Ball Ground. Adam is my coworker and colleague and kind of like mentor when I let him. And I work in business development there.
I'm Emily Day. I work at Twin Lakes Recovery Center, it's a substance abuse facility out in Monroe. We have an outpatient in Gainesville and we have a CE event coming up next month, or oh my gosh, it's next week, not next month. It's virtual. Merle Norton is the speaker, which I've heard great things about him. He's doing it on pharmaceuticals and xylitol. So
Hi, I'm Lauren Hairston. I work for the Insight Program, which is a drug and alcohol treatment center for adolescents and teenagers. And I work in the school as a substance prevention coach. So I meet with students individually struggling with addiction or anyone affected by addiction, and I do like small groups. And so I'm at East on Wednesday and Thursday, and then I officially started Central on Monday. The other 3 days. Awesome. Yep, got in there. Yeah. Very excited.
It is exciting.
So I'm Amy Dykes. I am the student support coordinator at North Forsyth High School and work closely with our Insight counselors that come into the schools. Yeah.
I am Katie Ham. I'm the Foster Care and Family Preservation Administrator for Forsyth County DFACS.
Sarah Pedre, the Director of Forsyth County Family Connection, which is the Georgia Family Connection Partnership for Forsyth County. We also have our drop-in center, which is a resource center for unhoused, unaccompanied youth ages 18 to 24. We have our jingle job coming up on December 14th, where 100% of our sponsorship dollars get to go right into our program.
Do you have a flyer for that, Sarah, that you're sending? Okay.
I'm Lindsay Kaiser, and I've known Sarah since I actually did leadership for Forsyth in 2018, and I recently switched rotaries. And so we kind of got reconnected, but I lost my sister 5 years ago to an overdose. And she actually came from the West Coast to come out here with myself and some siblings to try to get her settled in and actually did an overdose care. So anyway,
Welcome.
I'm a stepmom to 2 kids with addiction, and I mentor about 4 schools in our county, and I'm on the board of the Prodigal Child Ministries, and I'm with a mom's group on Monday nights of addiction.
I'm Cindy Mills. I used to be a commissioner in a former life, but I am, I love this drug council and all, the few of us that are still from the original group, starting it. I see that we're able to do a lot of good for the community, and I appreciate everybody that's here and that gives input into it. We're gonna need your help in the future.
I'm Dana Bryan, and I'm here because my 15-year-old daughter died because of the drug overdose.
I'm Isabel Song, and I'm a senior. I'm Sahasha Chakraborty, and as I said earlier, I'm a part of a club that does a lot of fentanyl awareness, and I'm a senior at Lambert.
My name is Simon Marty. I'm a junior at Alliance Academy for Innovation. It's like right across here in downtown. I'm just part of the council.
Daniel Rieta, counselor at Vita Community Partners, been there 10 years now. And we specialize in seeing people with either no insurance, we get funding for that, or Medicaid.
All right, let's just do a quick introduction of the people on Zoom. If Lisa, you could pull it up. Maureen, you want to go first because I can see you?
Okay, hopefully the picture's straight this time, but I'm Maureen Bixler. I'm a licensed clinical social worker and the owner of Live Life Counseling, Live Life Labs, and Live Life Sober. And we have an intensive outpatient program for youth and for adults that is for substance abuse disorders. So, and then we also do outpatient counseling. And then just a quick announcement, we do have our PALS support group every Monday night at 6:30 p.m. So parents of addicted loved ones, anyone is welcome, and it's completely free here at Live Life. So thanks.
And I'm getting out the flyer on that.
Okay,
Yeah.
thank you.
For anybody that didn't get to do the tour with the drug council at Maureen's place, on Tuesday, the mental health group that we have, that's different from this group, we are meeting at Maureen's place to get a tour and a talk from Maureen.
Lovely.
8:30.
Yes, thanks, Cindy.
Okay, Miss Erin Deedy, I see you at the top.
Good morning, Erin Deedy. I'm helping with the fundraising, and I'm a mom of a son in recovery.
Thank you, Erin. Miss Carolyn?
Good morning. My name is Carolyn DeSandri, and I'm from the University of North Georgia. I'm serving as the Dean of the College of Health and Wellness, and we have 2 of our programs that are delivered at our Forsyth campus, right in the heart there, Alpha Pilgrim Mill Road, our nursing program and our Master of Science in Counseling program that does have a accredited addictions track. And so I'm here just looking how we can be a great community partner and help y'all.
We are so happy you're here. Thank you, Carolyn. Miss Wilmer. Belle Wilmer, I believe. We'll circle back to you in a second. Miss Jennifer Johnson.
Hey, y'all. I'm sorry, I am here. Multitasking and on Zoom. I'm Belle Wilmer, and I am the mother of an addicted son also.
Welcome. We're happy to have you here. Miss Jennifer?
Hey, Rachel, it's Jennifer Johnston, Accountability Courts Director.
Thanks. Miss Allen? Ellen?
Hey, I'm just the reporter in the back of the room.
Yes, Miss Allen should be helping us out. She's a reporter who's been connected with us through PSI actually, and is going to help promote the Drug Summit and the Walk for Recovery. So we're excited to have her on board. Miss Janice?
Hi, I'm Janice Nyer. I do the newsletter. Rachel, you wanted me to talk about Giving Tuesday?
Yeah, you could.
All right. I don't know how many of you all have heard of it, but Giving Tuesday is an internationally recognized annual event. It's to boost generosity in communities. It's held the Tuesday after Black Friday, which is December 2nd this year. The idea is to set aside a day to counter consumerism by giving back to the community. Why it came on my radar last year, and I thought, wow, well, we should get involved with that. It's a way we could earn money, not earn money, but raise money for the council. We could recruit more volunteers. It's a way to get our name recognition, our brand out into the community. We can, of course, increase awareness by about the challenges and dangers that misuse of drug brings to the community. So, you know, how can we get involved? I mean, we could do it as easily or simply this year as putting out flyers on community boards, or ask retailers who are friends that can put them near their checkout. We can post it. Everybody's got online presence of some sort. You can post a picture of the flyer if we create one, on your social media sites. The flyer should, of course, have our donation QR code on it. Those are a couple things that just, sort of come to mind. We could work on, building this up each year to do a little bit more. But it was just an idea that I had. But, since I'm not local, my end is putting things on the newsletter and stuff. And so that's the idea behind Giving Tuesday.
Thanks so much, Janice, for all that you do. And last but not least, Sharmida, I did announce your award already. I didn't see you on Zoom, but if you want to say hello, and we all say congratulations for your CADCO award.
Yay.
Hi, everyone. I'm Sharmada. I'm the sector lead at our council. And then, as Rachel said, I'm also CADCO's 2026 National Youth Leader of the Year.
Awesome. Thanks. So as you can see, we've got a lot going on, but as we all know, drugs and alcohol also got a lot going on, so we got to keep up with it this way. So that being said, I'm now going to introduce our speaker. He is here from Northside. Kind of already said his name. Carrie, if you want to come on up, he is the manager of the clinical pharmacy services and is here. We kind of asked him specifically, as we're talking about fentanyl and the prescriptions, to go over what they're seeing in the hospitals. And then also, I asked specifically, I know I hear from a lot of you guys, like, we don't know what's safe to take and what's not, especially if you're seeking recovery. So he's going to kind of go over some of the pain medication that's safer to take, so that we can spread awareness on that with everyone that we are working with as well. So that being said, let's give a big round of applause for Mr. Gary Hall.
Hey, y'all. So I work for Northside Precise. So I've been a hospital pharmacist my entire life. Or well, not my entire life. Since I've been out of pharmacy school, seems that way. I'm old enough now. I worked at a hospital in Macon for 15 years. And my family and I, we moved to Cumming in 2016. People thought we had midlife crisis. And we found our way here. So yes, I have 3 kids, 2 in college, one at UGA, one at Sanford, and a sophomore at North. And if you see him, please make sure he uses his crutches. And my wife, some of you may know my wife. My wife is Amy Hobbs, and she works very much in the nonprofit world, has been a child advocate attorney in the past. She currently is the manager of a maternity home, working out of the Coming Women's Center's Living Hope. They assist with moms that are either homeless or on the brink of homelessness, and give them a safe place to have their child, and 18 months afterwards they can stay with them. So if the name sounds familiar, she's much more famous than I am. So people don't realize that when you come to the hospital, we have pharmacists working over there. I commonly get people think I either work at the home care pharmacy or either over at Lakeside, but we have a staff at Northside. Northside Forsyth, is part of the 5-hospital system, the mothership, Baby Factory down in Atlanta is the original. We have us in Cherokee, and then about 5 years ago, we merged with Northside Gwinnett over Lawrenceville and Duluth. So we are very much all growing hospitals. If you drive by the hospital, you can see it very much. Good luck finding a parking spot at North Forsyth right now. We currently park off campus and ride from the shuttle each day and everything. But I work in the hospital. And so we have a staff of about 130 in our pharmacy department, about 75%, well, about 60% of us are pharmacists. We've been very blessed in Northside. If you come to the hospital, you may meet one of my pharmacists out on the floors. We do a lot of patient counseling. We have pretty much every floor has a pharmacist based on the floor. We work in conjunction with our providers, with the nurses, and then do a lot of patient interaction while you're there in the hospital. So we do a lot of counseling and different things like that. Some of the things I'll talk about today is there's a new non-opioid pain medicine. Cindy asked me to talk about Journavx. I'll talk about some of the pain management stuff we do in the hospital setting, some of the safer pain management options, what we do as far as prescription drug monitoring. And while I'm here, I'm going to talk to you all about having a medication list, because we do that a lot, and then just overall security as well too. I'll try to answer any questions best I can. I was doing a cardiac rehab talk last week and spent 15 minutes on white bread. So I don't know, I'm not expert in everything, but I'll try my best to answer what I can. So you may have heard this new medication, Journavx, suzetrigine is, I'm from South Georgia, so I struggle with all these generic names. So I don't expect y'all, the easy way to say it is Journavx. This was approved by the FDA in January of this year. It's a first in class as a non-opioid analgesic, and it's really used to treat moderate to severe acute pain in adults. And the mechanism of action, not to nerd out too much on y'all, but it reduces pain by, it targets a pathway involving sodium channels in the peripheral nervous system. So it blocks pain but signals before they actually reach the brain. When we think about opioid pain medicines, they bind to the opioid receptors and mainly in the CNS. So the mu, the delta, the kappa. The mu is the one that you get the most pain control with. And y'all know about these opioids, morphine and codeine, the synthetic, semi-synthetic, hydrocodone, oxycodone, and fentanyl, and then tramadol as well. So it's a total novel, different approach to treat pain. And so that's why it's received a lot of publicity this year as it's going out. So again, it's a sodium channel blocker. It's available as a 50 milligram tablet. And the way we use this is it's a loading dose. So you give 2 tablets on an empty stomach to begin with. The first dose has to be taken on an empty stomach, kind of the pharmacokinetics of it, how it's absorbed. You can take liquids with it, clear liquids, even tea, juice, some of the broths, some of the things we use in the hospital when people are either on a NPO or on a liquid diet. So the maintenance dose is 50 milligrams every 12 hours, and you start 12 hours after the loading dose kind of deal. And so when this was looked to be approved by the FDA and everything, the primary endpoint of the studies was pain decrease over 48 hours. And this was used in the post-surgical outpatient setting. And also, Journavx has not been studied. It's only been studied for acute pain, and it's not been studied beyond 14 days. One of the things about it, it is metabolized by the liver. So we have to give dosing considerations for CYP. This is cytochrome, which are liver enzymes. So CYP3A inhibitors, inducers, and substrates. So we have to worry about people with either liver impairment or other drugs that are broken down by the liver kind of deal. So that's kind of a general. When it was studied, it was studied in post-surgical pain follow-up for abdominoplasty or tummy tuck or bunionectomy. There were some other studies where they did some orthopedics and plastic surgeries, different things. So really, when it was studied in the outpatient setting for short-term, what we call same-day surgery, outpatient surgery, not major surgery types and everything too. So ibuprofen was used as the rescue pain medication in the clinical trial. So this was studied, and I kind of talk about this as a monotherapy in the trials and everything. So some of the different surgeries, just mainly orthopedic, plastics, ear, ENT surgeries, and general surgeries. And if it's been used for non-surgical pain sources, so as we've been used more and more, it's been used in some of the acute pain settings. So mainly in extremities, so hands, feet, different things like that is some of the applications we've seen it used in so far. So its place in therapy. So whenever a new drug comes out, it has an application in different settings. If you look at the hospital, we do a ton of different things in the hospital. So we have outpatient surgery centers, we have the ED, we have patients coming in for infusion center treatments, different things like that. And then we have our general inpatient population that's either there, they come for after procedures, they come after surgery, different things like that. The main, it was not used preoperatively. So some of the thought was, well, maybe we could give this to people before they even have surgery. And then after surgery, you don't even have pain before it starts. Because of the drug interactions it has on it, it actually may decrease the efficacy of the medications given intraoperatively. So it has to be started post-operatively. So the setting really for this has been used in the post-op same-day surgery setting. We approved it at the hospital to give as a one-time dose in the PACU or the recovery unit after surgery. And at this time, the good things, you can get the loading dose. People haven't eaten, they just had surgery, so you can get it on the empty stomach. What we do is people have their own prescription and they're going home after discharge or going home that same day. So they have an outpatient prescription that they get filled as part of it. And then they take it once they get home and everything. Our ongoing questions, could this be used as part of a multimodal pain approach? I'll talk about that. That's the pain approach we use in the hospital. So it was used as a monotherapy, and this is great if it will work in that way because you can give this one non-opioid pain medicine for somebody who's having surgery that would typically get opioid pain medicines as part of their recovery process. So if we can work in that way and it will be effective, then that's great. It was mainly looked at decrease the pain at 48 hours or 2 days. And so some people, depending on the procedure, you can have a lingering pain much longer than that. And again, it wasn't studied past 14 days. So it appears for now that this is not like a long-term therapy choice, but if it's something we can do to decrease the amount of opioids given in this setting, then we're all for it kind of deal. Some of the drug interaction we have to worry about. So patients taking hormonal contraceptives, it can affect the absorption of those contraceptions. So we have to teach, we teach people who are given it. These procedures can be done on younger people. Worry about a second form of birth control if they are on that. There is in the animal toxicology studies, people read literature more and more, which is great, but we get a lot more questions. People may see something and that it reversibly, so it means it can go back, that in animal studies that affected female fertility. Nothing's been seen in the public about that, but we get questions when people see that. Grapefruit, so we always have to watch that. And just in general, if you are a big grapefruit drinker, please do so in moderation, okay? Because it interacts with a lot of medicines. So we talk about that too. People ask us, missed doses. The way this works, you have to take it on schedule each time. So for it to be effective and for your levels, it's not a reactionary drug. So it's more of you take it on schedule and not miss your scheduled doses. There is some drug-drug interactions. And so we always tell people, ask your physician, pharmacist, any new medications. As far as side effects, the great thing about side effects, very little side effects because of the mechanism of action. only 1% skin rash, 1% muscle spasms. The nausea and vomiting was 20-ish%, but it was the same as placebo. So these people is more related to the procedures they were going through and not the actual medicine. So it just FYI, when I say when we take drugs to the market, they have to compare it to something. Usually you can compare it to placebo. You have two groups. One person gets the drug, one person doesn't. You don't want to be in the placebo group. And then you compare the results and that kind of stuff. So as far as the genetics, some of the drug interactions we talked about. So the medicines it's contraindicated with clarithromycin antibiotic. We don't use that as much. Bioxin's the other name for it. Protease inhibitors, and these are fungal medicines. So that's like a niche. And then ritonavir is HIV medicine, so we'd have that. Dose reduction is needed. These are more mainly antifungal drugs, diltiazem and Multac and verapamil. Those are all heart arrhythmia medicines, so we don't want to mess with any of that kind of stuff. People may be on that therapy. And then the medicines we really have to watch about, these down here, I don't know if you see my pointer. Those are all the avoid use. Those are seizure medicines. So those are pretty known, highly reactionary medicines. So people know about that. So this is the problem we have that makes it a little bit more complicated is the genetics may decrease the efficacy of these agents. So apripitant is given for nausea during surgery. Ketamine, we're using more and more non-opioid to, and using some of its properties, meperidine, hydrocodone, fentanyl, midazolam, all those are used around surgery. The rivaroxaban, that is Xarelto. So Pixaban and Xarelto are blood thinners, and we don't ever want to mess with that kind of stuff as well. So we hate messing up those type of people's therapy. So that is part a little bit that gives us a little pause of some of the drug interactions it was causing. So it may not be for everybody. I won't go through this. Talks about some of the dose reduction we have to do based off people with the drug interactions. So Journavx, it has to be, the low dose has to be taken on an empty stomach. So that's part of the, a little bit as far as general population. That's why it's great in the surgery populations because these people are not normally eating. As far as the clinical trial, it was not no statistically significant superior reduction of pain compared to hydrocodone. So that's Norco or TAP5 is what you might know that. So in the trials, it compared it at endpoints as people were taking the Norco versus taking the Journavx, and so if it shows it's the same, then we can treat it as equivalent. Okay. So we'll learn more as this goes along. It's stated as a monotherapy, not a multimodal pain. The duration of use, if we could use it longer, that would be great. Worrying about people on contraceptives, especially young females. And then people with hepatic impairment or liver problems. So, and then the thing we always worry about is the cost. So this is that you being drug companies have to pay for studies, different things like that. It's about $15 a tablet. Norco, you're talking, less than probably 15 cents if cost for us. So cost wise, see, it could be cost prohibitive. The good news is there are on the outpatient setting, there are coupons the patient can use. The problem with the coupon, and a lot of that is going through right now, is Medicare eligible patients cannot use manufactured coupons for some drugs. I don't work in the retail world as much, so I don't know how this is all nuanced. We always try to find people with coupons for any of the high expense drugs we can and everything. So the good news is if you take it in an outpatient setting, it should be able to be used. The downside with it costing $15 a tablet, it's harder to get retail pharmacies if you have high cost medications to keep them in stock all the time, unless the demand is there to have your turnover so that they can have prescriptions used for it. What we are seeing with this is, okay, so we approved it, they give it the PACU, then the patients are given it on the outpatient setting and everything. The financial and continued literature review ongoing for potential future expanded inpatient use. Okay. Off the record, we definitely would like to see what we can use and what applications. We rely on what we do in hospital. We keep very tight reins on it. We are seeing in our outpatient our outpatient pharmacies at increased prescription use. Not all of it being dosed appropriately or for the appropriate indications, but some of the feedback that I've gotten from some of the providers who have done so is if I can decrease the overall amount of opioid or narcotic prescription use people, even by a handful of tablets, then that's better. What we worry about is that people hear that this is a new non-opioid pain medicine and they think it's going to be some sort of magic bullet that will be used for any kind of indication. For major pain, chronic pain, it does not look like that will be the application. As we get further and further use, it would be interesting to see what we can do.
Does it last 12 hours like they say, or does it wane off and you have to have Tylenol or other things? Or
so I have not had, there's not been enough with it just being approved and not the uptick of use, and we don't use on that patient. I don't anecdotally have as much of that kind of information. You brought up a good point. So if it is a monotherapy, what if somebody goes for an outpatient surgery and they're getting discharged, so they're not in the hospital, and they're not going back to see the physician. The dilemma for them is if we give the generics and it doesn't cover their pain as much, what they used in the trials was ibuprofen. We typically probably tell people to use ibuprofen with this and not Tylenol, since it does have the hepatic. We all know, don't take too much Tylenol. It's bad on, it can be bad on the liver. Too much ibuprofen can be bad on your kidneys and your stomach. So in moderation, so I tell people. So yeah. That is the key. Some what I've seen is, and what we've seen with some of our outpatient prescriptions is people still are giving smaller prescription amounts if people need to use the opioid if this doesn't cover it, kind of deal. I mean, it's a catch-22. You're not giving people as much, they're decreasing some. Are you totally using it as it's intended? Probably not. We'll just have to see as it goes out in the community and that kind of deal and everything. So unfortunately, right now, it does not have a huge scope for us to use inpatient, and anything we can do to get the amount of opioid prescriptions out in the general public or the amount is a good thing. So that's what we're looking for. So that's kind of where we're at right now. It hasn't been a year yet since it's been out, so we'll have to see. I know the approach we've taken in the hospital is a similar approach to the Metro Atlanta as far as the inpatient side of things, and it's really more of an outpatient use prescription. So hopefully it will provide. I have seen some for sure. We have seen some prescriptions for people that are on chronic pain management, and some of the pain management physicians have just written prescriptions for people just to try to see if it helps in any way. If it helps, more power to the person. Everything.
Do you know if there's other medications coming to substitute opioids?
So there's a big initiative by the FDA too, and some of that I'll talk about some of the things we do. So as far as things coming up, there's much more initiative to come up with other ways to cover pain besides just opioid. Now we have other mechanisms. I'll talk about it in a little bit. I'll get to it and everything. So yeah, there's stuff coming down the line. As far as what we do for pain management in the hospital setting, we have a hospital pharmacy and therapeutics committee. That's basically our overarching committee that approves any drugs that we use in the hospital. We have a restricted formulary, meaning that we restrict what medications we use in the hospital. By that way, we are able to keep costs down. We're able to keep more stuff safe. We also can kind of guide therapy to stuff that's been proven, whereas we get a lot of different stuff in community. And our medication administration limits it to patient areas. So everything we do in the OR, we might not do, everything we do in the OR and ED, we might not do on the general population floor. And then we have different floors in the hospital. We have our ICU, then we have a step down, then we have an intermediate care unit. And then we have a general med floor. So we do restrict what can be given on the different floors based off of that and everything too. We do have a pain management oversight committee. Actually, we had a meeting yesterday, and we look at a lot of things in the hospital as far as pain management oversight. We look at different therapy. We look at just yesterday we were talking about initiative to decrease initial dosing of different pain medications on different populations. So there's been a big push as your statistics were showing, also in the hospital setting of starting with decreased doses of everything to begin with, especially in our elderly population. Our medication orders and treatment guidelines, we standardize treatment as much as possible. So we want people, the days in old school, you'd have a chart physician write orders and they'd write out what they wanted to. Very much with electronic physician order entry, we can build what we call power plans. And so based off your treatment type, somebody comes from the ED, we use the ED pain management protocol. Somebody goes to the ICU, when they're in the PACU setting, we use a PACU or PACU standardized treatment. If you're coming in for a hip replacement or a knee replacement, we do a lot of those outpatient. We have a standardized treatment of those, and we get those people in and out now. They go to rehab. My joke is, I was like, eventually the hardest part of doing that surgery would be getting the seatbelt off of them because we get them in and out so quick. But it's amazing what we do with how quickly we can get people out of the hospital. As far as also, we have our pain management protocols. We have different risk stratifications. So we look at patients, their age, their body type. We look at a low risk of oversedation, high risk. And then we do everything off a pain management scale. So you have a mild 1 to 3 pain score, 4 to 7 for moderate, 4 to 6 for moderate, and severe is 7 to 10. The hard part about a pain management scale is, if I went around and checked everybody's blood pressure, I'd have an exact reading. The pain management is subjective per patient kind of deal. And so that's why we record these levels as much as possible. We use a nursing assessment whenever we give pain medicine. So nursing must do a patient assessment, record their pain level, their vitals, everything before doses, and then they record it afterwards too. So we can see if what the effect is on the patient whenever we're giving that too. And then I talked about standardized protocols, surgery type, procedure type. And also in the hospital, we have a pain services consult. So we rely on our anesthesiologists, some of the other providers that see this a lot, so that we don't have a ton of different physicians trying to treat different stuff. We have people that are requiring increased pain meds. We give it to the experts, and the pain services will handle those patients. We use what's called a multimodal pain management, and this is we combine multiple pain medications and interventions to achieve pain with fewer side effects. So we treat pain from a lot of different aspects. We start off in the hospital. We use acetaminophen, both IV and PO. Believe it or not, there is an IV form of Tylenol. It's not cheap, but we still use it because it decreases the amount of opioids we use and everything. And then non-steroidals as well. Ibuprofen is probably the go-to. There is an IV form called Ketorolac. Toradol is the brand name of that. It also comes in nasal spray. If you've ever used that in the outpatient, it's called Sprix. Very good for migraine treatment and everything too. So what we do is we start people off with Tylenol and our non-steroidals, or sometimes both. Get those on scheduled doses. We add in muscle relaxants, so we can give those IV or PO. So either scheduled or PRN. The gabapentinoids, so gabapentin or pregabalin, so Neurontin or Lyrica. So some of y'all, we use that a lot for nerve pain. So we're not actually touching the opioid receptors. And those bring in other potential for, all of these medicines too do have potential for abuse as well. You find in the setting that there's a lot of overuse of different types. But by using lower doses of a lot of different medicines, we can typically keep patients' pain under control. And then our goal is to use opioids for breakthrough pain only, and not as the main baseline for our therapy. More recently, we do lidocaine topical patches. And then I didn't add on here is we use physical therapy a lot. So we try to get patients out of bed. We use physical therapy, different things like that to get people up and moving, so that we're not just treating everything with medicine, okay? And then we think about other things, whether side effects with opioids and different medicines, one that, antiemetics, so anything for nausea and vomiting. Then we have to think about the bowel regimen. Even though the opioids are mainly trying to hit the receptors in CNS, you get them out in the peripheral. So that's where we have problems with constipation, different things like that. So we go ahead and get people on a bowel regimen so they have bowel movements, and we don't deal with that. And then anybody on our pain medications, we have rescue narcotic reversal, naloxone, different things like that we use readily available if we should have an oversedation. We do monitor oversedation events in the hospital. Our goal is not to have any oversedation, anything like that, but we do watch for trends like that in the hospital so that we know our weaknesses as well. So other pain treatment options we use, and some of you may have ever used, we use PCA pumps, was actually interesting. So rather than giving people IV pain medicine, you know, like you have to ask your nurse for it, these are actual pumps that we can set with very low demand doses with timeouts. And so the patient feels more control of their pain. So basically you have a button and then they can press and give themselves a medication, a lower dose throughout therapy, but it has lockouts where they can't get too much. Epidurals, we use this very much in spinal surgeries, but more where you probably see it more is in our L&D world. So, you know, with Northside, we have a high population of giving, you know, birth and babies is one of our mainstays. So we use the PCAs a lot. Liposomal bupivacaine, so Exparel, we use this in the surgery setting. It's actually a local anesthetic with a liposomal, meaning it absorbs in fat, lasts a long time. Around the surgery, we can put this around the incision site and helps prevent that. Nerve blocks, epidural treatments, intrathecal pain pumps. A lot of those are different surgeries so that we're giving people concentrated that need to be on chronic therapy so that they're not continuously getting oral medications, and we treat their baseline therapy. One thing that I didn't include on here that's actually pretty cool is we started using something that's called a Qtenza patch, which is capsaicin patches for people with diabetic neuropathy pain, particularly in their feet. We do this over in our pain clinics. So they come in and they get these capsaicin. They're really high dose. Don't go home and try to rub chili powder on your feet. It's not going to. So they give these patches and it helps with a lot of nerve pain. And then we give special consideration for populations, cancer pain, sickle cell pain, and then palliative care treatments, different things like that, where we do stuff to make people comfortable kind of deal. The sickle cell pain, one thing that we do, we see that this population is very much requires a lot of pain and they develop a high tolerance. We try to treat these as standardized as possible because inevitably it would be interesting how far your sickle cell pain patients travel to go get treatment based off of the different treatment regimens. So we try to standardize approach to that so that we don't have patients seeking specific physicians, if you know what I mean. Chronic pain management, one thing that we do is we follow the REM strategy. For anybody who gets a long-acting or extended release medications, OxyContin, fentanyl patches, anything like that, we verify in the Georgia PDMP. I'm not sure if y'all familiar with that, the Prescription Drug Monitoring Program. So we can go in there and look and see what patients have had filled. And we have to look before we give anybody an initial prescription or we fill any prescription. If somebody comes to the hospital, you say, when you come to the hospital on your medication list, if you say you take OxyContin twice a day, we go in the Georgia Prescription Drug Monitoring Program and make sure that this is accurate information, that people have had these medicines before, particularly that we're just not, because the potential for oversedation or overdose on any of these is highly likely. With that. So we use that looking through the Prescription Drug Monitoring Program. If you're not familiar with the Prescription Drug Monitoring Program, prescribers and pharmacists, all prescribers with a Georgia DEA number must enlist, and they are required before a first-time prescription for benzos or opioid medicine, Schedule 2 or higher, to go in the Georgia PDMP and check. There are exceptions if it's a short term, if the patient's in a healthcare facility, a hospital, nursing home, somewhere where their care is being provided for them. If it's a very small amount of medications, if they're in a terminally ill, hospice, or cancer treatment are some of the exceptions. Pharmacies are required to enter any medications we fill in this program within 24 hours. So we follow up on that. And just FYI, patients can request a copy of your PDMP prescription report by filling out a release information. So if you ever need to check one, this is something you can have access to. You may not have, it's restricted who can access the system, but you can get a copy of your own records if you ever need to. Things we do, our hospital population, absolutely, we deal with the elderly population more so. We've got initiatives to reduce things in patients 65 and older, lower doses of medications, reduced our big initiative right now, especially for our older population, is to reduce, so reduce the duplicate opioid treatment and then also our opioids and benzos treatment. So, always keep a good accurate list of your medications. You come to the hospital because please don't use multiple pharmacies. And always ask your pharmacist about OTC medications. Keep your medicines severe location. There are expired, I know y'all use the drug disposal bags. Do you know about the mail back envelopes system now? So you can actually, there is a way, if you just Google prescription mail back envelopes, you can use those. The areas that are not, that we worry about theft from, veterinary offices, typically not as secure as hospitals, different like that. We've seen reports, we have to alert our ED physicians, they see stuff laced with stuff from veterinary offices, and then obituaries. I always tell people, unfortunately, people do read the obituaries to go break into people's houses. Especially if they know the indication, say if somebody was on long-term cancer treatment, something like that, that does happen. As far as drug disposal, if you're all aware, Forsyth County, you can go to their website. They do have drop-off locations. We have people bring stuff to the hospital. Unfortunately, we can't collect those from patients. We do have our own destruction, but the Forsyth County Forsyth County Sheriff, and then also the CVS on Post Road. Also,
Used to have a box. Didn't you used to take it back there and do it in your incinerator?
Possibly. I'm sure that was probably before a lot of EPA laws and different things like that we have to. So we have we have a very thorough drug disposal process. Things don't go down the sink, anything like that kind of deal anymore. So sorry.
No, you're fine. You actually did pretty good for the most part. So
Rachel, I want to ask
Yeah.
one question just because there's people
Well,
there.
to answer your question, yes, there very much is an initiative to encourage drug makers to seek non-opioids straight from the government, non-opioid pain medications, and there are things in the pipeline. The things that people have done is there are many where they take, we can use liquid gels, we can use different formulations. So if medications are crushed, the problem with OxyContin, different things like that, people used to crush it, snort it, inject it, different things like that, because it tended to be long action. As soon as you manipulated it, it became short acting, that kind of deal. Very much stuff in the process to where either to make manipulation resistant, either by the physical structure or by adding different things like adding naloxone to it at low doses. Orally, it doesn't affect absorption. If you crushed it and injected it, IV, it would affect the effect of it, so you wouldn't be euphoria of it, different things like that.
Thank you for that, and thank you for coming today. But we have a lot of people that are involved with the drug council that are in recovery, or they've got family members. On your special population, I've just heard from people in the recovery community that if they have to go in for a surgery, it's like fighting against the norms of trying to say, I don't want that. I can't have opioids. I can't have this. Is there a way of making people in recovery be able to have a special place and not have to fight so hard not to be given the drugs?
Well, and I think there's a shift very much of people advocating for non-opioid pain medicines, different things like that. So I understand what you're saying. We are very sensitive to that when people come in. So we reach out to a lot of the methadone treatment centers. We have to fill out a release to make sure that we keep people on their scheduled doses. Very much Suboxone use is much easier for us to get and find that information out to keep people on their thing and to make people aware. That goes back to the patient medication history. One of the hardest things for us is getting accurate lists of patient medications when people come into the hospital and do things. We've actually reached out to the people who tag the great white sharks to see if we could do some tagging of patients. So when they come back to us, we know exactly. That was a joke. It would be great. That's the hardest part is getting an accurate list of people of what people are on. And understanding as to what people are seeking outpatients, so we can either continue it or we can either be sensitive to the reasoning why people are on different things too. So very much so. Yes, ma'am.
I just wanted to address what Cindy was saying. Part of the responsibility of those of us who are in recovery are so that our doctors know that we're in recovery. And that can be very difficult Because, you know, your mind will say, hey, listen, I used to be able to use these to feel something. Oh, I got a broken foot, I can feel it again. You know, so it can be a double-edged sword sometimes. But one of the things that, me personally, 'cause I am in recovery and I broke my foot and I had some implants done. And anyway, I let them know, listen, I'm in recovery. So we're not gonna do the narcotics. And I got through it on ibuprofen and Tylenol. I never thought I could get through something like that, but you can.
Yeah, Heather Hayes was who mentioned it to me, and I can't remember if she had I can't remember, gallbladder, something, and a scheduled surgery, and she had to constantly, you know, like, it wasn't like you just, and this has been probably 7 or 8 years ago, maybe longer. But she said that she was having to constantly remind the people, no, what are you giving me? I can't have that, you know, like, it was.
You have to advocate for yourself. But I think that the hospitals are getting a lot more progressive with, okay, it's in your chart that you're in recovery.
It sounds like it.
Yeah.
Yes.
Yeah.
I know, because I go to Emory and it's in my chart
Yeah.
and they all know. So whatever doctor I go to in the Emory system.
And especially so much about opioids
But
now.
now, yeah, I think it's gotten better.
Okay, everybody, well, we are gonna hash it down to a big round of applause. Thank you, everybody, for coming out on that. And on that note, we do have Narcan for you to take. Anybody who needs it, it's free. It will always be here. Again, the point of these meetings is to collaborate with each other. So if you have a minute afterwards, say hello to your neighbor. Let's all try to work together and see it done.
Thank you, Gary. Thank you. Right down.